So it's Friday, so it's time for Poets. Some of us know that as Push Off Early, tomorrow's Saturday, but in this context it's the Perioperative Enhancement Team. Inspired by Dr. Sol Aronson and the team at Duke, a selection of clips to get us thinking about the next steps in providing world-class perioperative care. You'll find the full lectures in our back catalogue, or join us at the upcoming Perioperative Practicum for expert discussions, business case tips, and hands-on workshops. Go to www.ebpom.org and look for our international programme of perioperative practicums. Top Bed Talk. I'm absolutely delighted that you gave one of our key plenaries today, and you spoke to us about risk in particular. And I learnt about some new terms. I was very distracted by how many of these things I'm losing by the various different risk factors you described. Was it micromorts?
Micromorts, yes.
Okay, tell us all about that.
Yeah, so micromort is a 1 in a million chance of death, and really the concept of micromort is a statistical issue. It's a way of stratifying risk or converting risk into whole numbers in a way that you can then make comparisons with different activities, and it's easier for people to understand what maybe relative risk is. So, for example, when talking to patients, as I was mentioned obviously in the lecture, as doctors, we're often not very good at getting patients to understand risk. You know, we can tell them all sorts of things. They have a 1 in 100,000 chance of this or a 1 in 50,000 chance of that. But often patients can't really conceptualize what that actually means in real terms. So if you can use that to make a comparison with an activity which they may be more familiar with. For example, like saying, 10 micromorts is the equivalent to, say, driving 2,500 miles in a car. It's equivalent to driving 60 miles on a motorbike in the UK, probably going about 5 miles on a motorbike in China, for example. But so there's just an idea. It's a way, I think, that sometimes can be used to try to help with understanding of relative risks of things, yes.
And you gave us some, as you said, some common examples of things and a sort of hierarchy of risk. And I think lots of us have heard this before, but for example, walking compared to driving, which is the riskier?
Walking is actually appears to be more dangerous than driving.
Okay, and riding a motorcycle?
Riding a motorcycle is one of the more dangerous ones. I can't remember. You put me on the spot here. I can't actually remember offhand whether that was worse than walking. I suspect it is worse than walking, yes.
And skydiving is?
Skydiving is actually relatively safe, interestingly. Skydiving...
Surely not more than walking.
It depends where you're walking, I suppose. It's funny skydiving because obviously skydiving, it's a kind of a dramatic example because people will often expect that skydiving is very, very dangerous. Yes. But statistically, skydiving is not all that dangerous. You mean one of the comparisons I made, for example, was the data from the UK in 2009. The risk of spending one day in hospital or one night in hospital is approximately around 75 micromorts, which is 7 times more dangerous than skydiving.
Wow. Okay. And flying's relatively safe.
Flying is actually one of the safest modes of transportation because what you're looking at is the distance covered in comparison to the risk of an event resulting in morbidity or mortality. And mortality specifically, actually.
You gave us an example that we tend to be very fearful of things that are actually very, very uncommon. Like I think you said shark attacks and terrorist attacks, which are very sensitized to in London.
Yes, of course. I mean, this unfortunate events we've had in the last few years, it's affected London particularly, but other cities in Europe. It creates an irrational, what is really is actually an irrational fear because your risk of actually dying in a terrorist attack is not high at all. Yet these things, because they feature very prominently in news, etc., they capture the fear and imagination of the public, and I guess one of the reasons the terrorists do it is actually to do that, and it generally has that effect. So people will be, they should be actually, if you look at it statistically, they should be more scared when you go to a doctor, see the GP, and he gives them a medication, because that medication may be more dangerous than the risk of being killed by a terrorist. But they they don't think like that.
So you're more likely to die from side effects of medications than a terrorist or shark attack. Okay, so now let's talk about major surgery and anaesthesia then. So we often talk about assessing people's fitness for anaesthetics, but what are the chances of dying, what are the risks of dying from an anaesthetic per se?
Well, the very latest data that we have on this is that I could find anyway was from Australia and New Zealand, where they keep a very good database of perioperative mortality, and the actual risk of dying from anaesthesia specifically, and it's a very important distinction that you made there, and it's a major irritation of mine. I find, in the hospital, people talking about the risk of anaesthesia as opposed to risk of surgery. The risk of dying is probably less than 1 in 500,000.
Wow, very, very, very rare. But dying from, let's pick a surgery.
When you think that it was 1 in 2 or 3,000 only 50 years ago. Yeah. So think of the advances that have occurred from our work of our peers that have reduced that risk so significantly.
And I know there's a variety of open heart surgeries, and Sol, you'll know more about this. What would you quote as a sort of common risk of open heart surgery, bypass surgery, open chest on bypass? What broadly speaking, what numbers do you quote in the US?
In the US, it's pretty common to ascribe a 2% plus or minus 1% risk for an otherwise standard, if you will, coronary bypass. And that doubles if it's an emergency, and it doubles again if you're high risk in an emergency. It's a wonderfully interesting conversation, because as we engage, I just wonder if we are doing justice to the discussion about risk. Not only what is the direct risk ascribed to walking across the street, or something passive like being struck by lightning, but what of the risk of not having the outcome that you want, yet alone the complication that would be, addition to, if you will, the act of the surgical event or the anesthetic event or the walking across the street event. A risk is you wouldn't ever get across the street, not just getting hit by a car as you cross the street, I guess.
And then if we move to example like some common cancer surgeries, that the risks are many, many, many more fold higher than the anaesthetic per se.
Yes, that's correct. Yes.
So,
in fact, you could argue that anesthesia is actually probably reducing their risk of death or complications because of what we do to mitigate the stress response to surgery, and reduce pain and improve physiological function in the perioperative period.
So then I'm going for surgery, and let's imagine I am. There's a tendency for us to look up figures and get quoted the overall risk of this surgical procedure, i.e., in the country of England last year, the known mortality rate for this type of surgery was 1%, 2%, whatever it is. What about my personal risk? How can I get a better handle on that? Because that's what I really want to know about.
Well, that's obviously difficult. I mean, there are ways in which we can do kind of risk assessment, and the NELA data that's coming from the UK.
NELA standing for the National Emergency Laparotomy Audit.
Yes, I think so. So this type of information can help us historically to know what your particular comorbidities will increase your relative risk. So, for example, if you're a diabetic or a poorly controlled hypertensive, this type of thing, we can use these type of information to make a better calculation of your personal risk.
Nick Majerison here. On August the 11th, 12th and 13th, the American Association of Nurse Anaesthetists will be holding their annual Congress. Top Med Talk will be coming to you with live updates from the meeting as it happens. We'll be interviewing thought leaders, academics and prominent practitioners for 3 days of discussion and debate. The opioid crisis, enhanced recovery, innovations in anaesthesia and much, much more. Guests will include the president of the AA&A, Gary Bridges, Lynn Reed and Lorraine Jordan, to name but a few. To get ahead of the curve, why not listen to some of last year's podcasts from the AA&A? Simply go to topmedtalk.com and type into the search engine AA&A. Pop that in and you will find our output from last year. In the meantime, of course, if you want to find out more, the American Association of Nurse Anaesthetists are holding their annual Congress August the 11th through till the 13th. Go to topmedtalk.com for more details, and while you're there, make sure you subscribe to Top Med Talk, and of course, that you've joined us on social media. That's topmedtalk.com.